Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years. Hello and welcome. Today's presentation, Why Does My Ankle Hurt? Causes and Treatment of Ankle Pain, is presented by Dr. Jet Liu, Orthopedic Surgeon with Washington Township Medical Foundation.
Hello, good evening, everyone. Welcome to join us. And our topic today is common causes and treatments of ankle pain. My name is Jet Liu. I'm practicing as an orthopedic surgeon at Washington Township Medical Foundation, and I specialize in foot and ankle reconstructive surgery. A little bit about myself. I received most of my education in Texas, ended up doing a foot and ankle reconstructive fellowship after orthopedic residency in Cleveland Clinic in Ohio, and then relocated in the Bay Area along with my wife and my dog about 2 years ago, and currently enjoying every bit of the sunshine in the Bay Area. The reason I got into the foot and ankle and was so passionate, that kind of interested me, is kind of the biomechanic nature of the foot and ankle. I believe a lot of the pathology associated with that is somewhat ignored or underappreciated. A lot of times when you have an ankle pain or foot pain, is often, what I say is walk it off and it will feel better tomorrow. A lot of times that's related to kind of a biomechanical etiology, and that can increase the risk of some kind of causes. And that to me is interesting because a lot of times once you know the reason, you kind of can treat it from a biomechanical standpoint. And often the good thing about that is it can be treated non-surgically. And a lot of times also in case of things that doesn't work out, as we later explore in this presentation, surgical options there for you. So let's dive into kind of what the ankle is all about. I just want to introduce kind of the nature and basic anatomy of the ankle. And firstly, this is kind of what the ankle looks like from a bone perspective. You can see the ankle is a hinge joint that forms is articulation formed by three bones, two bones in your leg, which is the tibia and the fibula, and one bone in your foot, which is the talus. And the function of the ankle is mainly dorsiflexion or plantar flexion. What that means is allow you toe up and toe down. And that carries most of your motion when you're walking and forward. Now there's another joint that's below the current ankle joint that to me is also very important. That's called a subtiller joint. And this joint locates right below the talus, which is what consists of the ankle joint, but the talus also articulates with the calcaneus, which is your heel bone. And this actually allows you to move your ankle sideways, which what we call eversion and inversion. And this joint is what we kind of use a lot to accommodate different terrains, such as uneven ground and so. And then now if you can have a chance, or in the previous year or right now, if you are standing up and you have someone to kind of look at your alignment of your foot and ankle when you're standing, you might find yourself falling into one of these three categories. Now, most of you probably is what's in the center, which is neutral. It's perfect, straight up and down, no other problems. But some of you might fall into the left and right. The left is what we call pronation. What that means is you're putting extra pressure on the inside of your ankle. On the right side was what we call a supination, which means that you are putting extra pressure on the outside. A lot of times, more layman term, on the left side, what pronation is what we call a flat foot. On the right side is what we call a high arch foot. Now that can cause some problems. I can see what pronation means is you have a low arch, your heel and toes turns out, and as a result, there's increased tension on the inside of your ankle. Now, what we mentioned about the biomechanical nature of the foot and ankle is not only there's bone, but also there's soft tissue related on either side of your leg. In this case, there's a set of tendon on the inside of your ankle that might be exposed to increased pressure as you put more tension on the inside. That in turn can cause something called a tendinitis. So in this case, there's a tendon called a posterior tibialis tendon, and oftentimes that can be associated with flat foot or pronated foot. And this is kind of what the tendon is. It's a tendon that connects the muscle in the back of your calf to the inside. And that tendon allows us to kind of walk forward, but also allow us to hold the arch of the foot up. As you can see, if you have a flat foot, that can cause a lot of problem with that tendon. On the contrary, if you have a supinated foot or high arch foot, you'll find yourself heels turns inward. As a result, there's increased tension on the opposite side of your foot, which is the outside of your foot. And then these can be associated with a different set of problems. There are soft tissue on the outside that can be exposed to increased tension. And these are what we call the perineal tendon, as well as a set of ligaments that kind of hold your ankle together to prevent ankle sprain. So if you have a high arch foot, you'll be having more problems likely with perineal tendonitis or recurrent ankle sprains. And from an anatomic standpoint, it will make sense. As you can see, these tendons kind of comes around the outside and holds your ankle stable from that standpoint. And we'll kind of dive into these structures and their functions later on. And now I kind of like to break down kind of the common location of the pain and then the common reason and common treatment for each cause. So let's say if you have more pain in the front of your ankle, and that's in the shaded area, and there's three things that I think about that's most common when someone complains of what we call an anterior ankle pain. Will be ankle impingement syndrome, ankle arthritis, and what we call the OCD or OCL or talar osteochondral lesions. And we'll kind of break down into each individually. We'll talk about ankle impingement syndrome first. So what's ankle impingement syndrome? When we talk about impingement, it means pinching. And what the ankle impingement means, there is some kind of bone formation on the front of the ankle, whether it's on the undersurface of the tibia or on the top of the talus. So every time you are moving your ankle up or toeing up, you're essentially hitting bone on bone, and that causes a lot of pain and swelling in the front of the ankle. And we know that these are associated with a younger population, especially with more active individuals such as soccer players or dancers or football players. And it can be quite debilitating, especially every time you are moving your ankle up. More commonly, let's say if you try to squat down or you're trying to kneel down with your ankle kind of with the forefoot on the ground. These people either can't do it or have severe pain when they're trying to do that. So they have a great limited range of motion with ankle dorsiflexion. As you can see on the x-ray example on the right, you can see there is a little bit of a lip on either side of the front of that joint. As you can see, when the x-ray on the right, when the patient tried to kind of dorsiflex the ankle, the impingement happens. And what do you do with these things? As you can see, there's a common theme with a lot of foot and ankle conditions that we're going over today. The first line treatment is always non-surgical or conservative in nature. In this case, because there's pinching, the conservative option often consists of a combination of heel lift, meaning that we try to limit the amount of dorsiflexion you have when you're walking by putting a little bit of lift in the back of your heel, in your shoes. Activity modification, meaning that we try to justify the regular exercises, maybe shy away from activities that allow much or that introduce a lot of dorsiflexion to control the symptoms. Anti-inflammatories is always an option, and also corticosteroid injections, which can relieve some of the local inflammation in the soft tissue in the front of the ankle. And then if these things doesn't work over a long period of time and the symptoms are still debilitating, then there are surgical options that can take away the actual bone spur in the front of the ankle. And we can do this through arthroscopic, which means making tiny incisions in your skin and work everything from the inside with little cameras, versus open, meaning that making a little bit bigger incision and visualize the bone spur directly and take them out. So this is an example of arthroscopic procedure. As you can see, we kind of like building a ship in a bottle. We kind of put little cameras inside and visualize what the bone spur look from inside and introduce tiny little bit of instruments to take out the bone spur, as you can see on the image on the right. And most people do very well actually with conservative management, but again, surgical option is always an option for you, just in case if you fail to improve. Now, next topic is ankle arthritis. Now, these are more geared toward older population. Usually there are three main causes for this. Post-traumatic, which actually about 67 to 70% of patients from developed ankle arthritis is due to some kind of previous injury, such as fracture around the ankle. Primary osteoarthritis consists about 10%, and there is a little bit less percentage of inflammatory arthritis, such as rheumatoid or gout, that can kind of result in ankle arthritis as well. Again, the symptoms are anterior ankle pain, stiffness, swelling, and worse with prolonged weight-bearing activities. And why weight-bearing activities? You can see we do put all our weight through our ankle when on our feet. So on the left X-ray, you can see what normal ankle look like. The joint line is congruent, is clear, it has symmetrical spacing in the front and the back. When you have arthritis in your ankle, then what that means is you have some degenerative changes within the ankle joint, and that can lead to decreased amount of space, bone spurs forming front and back, and as well as increased amount of friction. So every time if you're moving your ankle up and down, the pain would result. And what do we do with ankle arthritis? If you have ankle arthritis, a lot of times weight-bearing activities might be what's limiting your activity. So in a way, if you like to do some recreational exercise around the fact that, to minimize the movement of your ankle, there are activities that can get around that, such as aquatics, such as biking, such as some of the maybe yoga, some of the non-contact or non-weight-bearing activities that you can do. Shoes. There are shoes that's called rocker bottom shoes. This is the shoe that converts the stiff ankle into a more mobile one by allowing the shoe to kind of help you move you forward for you from that design perspective. Weight loss. We know, weight loss, a lot of times a little bit less pressure through the ankle. We know that from a biomechanical standpoint, 1 pound of our body weight translates into about 3 pounds across our ankle. So in a way, if you lose 5 to 10 pounds, your ankle would be translating to 15 to 30 pounds of pressure across the ankle. But so in that by itself might make you feel a lot less symptomatic. Like I said, anti-inflammatories is always an option. In the end stages, there are braces that can be customized to you. What that means is AFO. What that stands for is ankle foot orthosis. So these braces are customized and designed to kind of really limit your ankle motion. The idea is if you are arthritic and every time you move your ankle up and down is what generates pain, maybe limiting your ankle motion would make your pain better. And then lastly, injections, just like any type of arthritic conditions, it provides a temporary amount of relief through numbing medication and corticosteroid. Now, if you try those and those non-surgical options and you're still not satisfied with the results, there are surgical options as well. Now, there are two main surgical options for ankle arthritis. There are ankle fusion or ankle replacement. So on the left is an example of what ankle fusion is. It is exactly like what it sounds like. So what you're trying to do is to glue two bones, mainly the tibia and the talus, and allow them to form into a one bone. So in a way, you're sacrificing motion in gaining essentially resolution of pain. So these are historically very well described. They're more commonly served in young active patients. It is considered the gold standard surgical treatment for ankle arthritis because it provides the longest track records and of the most reliable relief of pain. There are some risks, just like every surgical procedure. The main risk for ankle fusion would be somehow the purpose of a fusion is to glue two bones into one. Now there is always a risk of the fact that the bone was not able to glue together. So that's what we call a non-union, and that can lead to persistent pain. And secondly, ankle is a mobile joint, just like joints surrounding the ankle, such as the subtalar joint or the joint in the midfoot. Now, if you're fusing one joint that's supposed to be mobile, the rest of the joint are naturally getting more pressure through those, so that you can develop adjacent joint arthritis. And then for ankle arthritis, so for ankle replacement is another option for ankle arthritis. So that's exactly what the picture shows on the right. Just like the more common procedures you see nowadays with hip and knee replacements, ankle replacement is essentially cutting away the surface that's arthritic and replace it with metal and a smooth articulation with the metal and what we call a polyethylene, which is a spacer between the metal. This is clearly described a good treatment in less active patients. The benefit of the ankle replacement is theoretically preserve ankle motion. So you're able to move ankle up and down still. And that translates into increased walking speed and increased stride length. And the risk of that is because we're putting in more delicate implants, there can be higher complication rates related to that, such as loosening, such as wear and tear. So this translates into a higher revision rate. And currently, we're studying ankle replacement into third generation now, and the results has been very optimistic, but we're still lacking some of the long-term studies. And next, we're talking about talar osteochondral lesions. So these are definition will be area of abnormal or damaged joint surface or cartilage and bone over the talus, which is what we consider the floor of the ankle joint. And these are often associated with traumatic injuries such as ankle fractures or ankle sprains. And most of us probably have sprained an ankle in our lifetime at some point, and these are often present but underdiagnosed. And this can translate, again, persistent anterior ankle pain, swelling, and worse with weight-bearing activities. If you take an x-ray of someone who had sprained an ankle with persistent pain, you might find some similar findings such as the x-ray you see on the left. You can see the corner of the talus and the tibia, there's some kind of lucency there. And if you do an MRI of that area, you might see an increased signal, which signifies a little bit of bony edema or bony swelling that can translate into persistent problems. And what do you do with this? The first line of treatment is again always conservative in nature. You can try a short period of immobilization, plus minus bracing, and advance to physical therapy. See if you do well. Now these are often less successful than we desire with non-surgical options. With about 45% of the time, they report a good and satisfying results. But again, that's not a good percentage if you consider 50% of the patients still has persistent problems. So that translates to a more surgical option. Now, just the overall algorithm of surgery, I listed 3 most common options. And the grand scheme of things, these are more geared toward the size and severity, location of the lesion. So let's say if your size of the lesion, as you can see on the picture below here, if that is small, now we don't get any technical, but if that's small and that is loose, we can go in with little cameras and take out a loose piece and somehow stimulate some bone healing from underneath up. So essentially trying to stimulate your body to kind of grow some pseudocartilage to kind of fill in that pothole. Well, if the area is small but is stable, meaning that there is a stable roof over that, sometimes we can retrograde, so meaning drill from the other direction to stimulate some healing from underneath while not disrupt the rooftop, and that's what we call the retrograde drilling and bone grafting from below. Now, if the area is huge, and that has demonstrated kind of a poor outcome if you do the first 2 options I just mentioned, then we're considering some of the bone grafting options, whether it could be a bone plug that you harvest from your own body somewhere, or a donated bone that can essentially plug into this area and kind of smoothing that out. And historically, this has a good, somewhat a more optimistic outcome, 60 to 90% good, excellent results. And again, it all depends on the location, the size, and severity. And then let's say we're going to talk about kind of pain on the outside. So this is the outside of your ankle. If your pain is kind of located in the front of that pointy bone, in the outside of your ankle, and I think about whether you have history of ankle sprain that can translate some recurrent ankle instability, or some kind of what we call a sinus Tarzan syndrome, which we'll go over. And then it could be also something called a subtitle arthritis. Most commonly, I would think about ankle sprain. So a good history taking is very important. Just what an ankle sprain means is injury to the lateral ankle ligament. There are 3 of them, as you picture there on the right there. So if you picture that your ankle rose, and most of the time when we sprain an ankle, our ankle rose inward, right? So your toes pointing to the inside of your body. So you put these ligaments on some kind of strain, right? What we call the anterior tibiofibular ligament is usually the first line of defense, and if the force is great enough, it kind of translates to the calcaneofibular ligament, which is CFL, and then if the grace is if it's too great for that, then the third line defense is called a posterior tibiofibular ligament, so PTFL. So it all depends on kind of like the force of the sprain. And these are associated with risk factors. Like I said, if we sprain an ankle, which most of the time us have done during our lifetime, there is somewhat increased chance of you sprain an ankle again. So previous ankle sprains is one of the risk factors. If you have a high arched foot, if you remember from the slides before, you are naturally have about mechanical disadvantage of putting more pressure on the outside of your foot anyway. So over time, you have a tendency from the alignment perspective to sprain your ankle. And some people are born with more ligament laxity. So in a way, these ligaments are by nature a little bit more looser, and you have a more risk factor of spraining your ankle. And what's important is, ankle sprain instability are 2 different concepts. So everyone can sprain an ankle, but very few people have a gross instability. What that instability means is you actually have an increased laxity, meaning that your ligaments are looser after you sprain compared to the lateral, contralateral ankle compared to the other ankle. There's 2 clinical diagnostic testings we do. One is called an anterior drawer test. So that basically was pictured on the right there under A. What you're trying to do is to stress the ATFL, by putting kind of a more anterior pressure on the ankle and posterior pressure on the leg there to see if you have a gross translation that is different than the contralateral side. And then Taylor tilt test, what that means is you're trying to stress the CFL, which is the calcaneofibular ligament, by kind of reenacting the force of your injury to see if you have a gross laxity from that standpoint. And this is, like I said, compared to the contralateral ankle to make sure it's not a physiologic laxity. And X-ray can be a really useful tool for diagnosis, or what we call stress views. So if we're doing anterior drawer test and the Taylor tilt test and it's grossly lax, you see the finding on the X-ray on the right there. So you can see when you do that, there's an incongruency of the ankle joint. So this whole foot translates in relationship to the leg. You can see there is much more distance between the joint line in the back compared to the joint line in the front. Same thing with the Taylor tilt test. When we tilt your ankle, there's a big difference in the joint line space between the inner portion and the outer portion. And that's usually diagnostic for what we call the ankle instability. MRI is usually not diagnostic, but it's a useful tool to kind of confirm the injury sustained from prior ankle sprains. And usually it's very helpful for us to pre-operative plan in terms of assess the quality of the ligaments that remains. Again, what we do from the first line, non-surgical options. So if you sprain an ankle, you probably benefit from a short course of immobilization to allow the inflammation to calm down, then eventually transition to some kind of brace so you can walk in the regular shoes. And then you, for the long term, you probably benefit from a dedicated course of physical therapy, which mainly consists of 2 things. One is perineal muscle strengthening. What that means is you're trying to kind of tighten up the structure on the outside of your foot when you sprain, which is you stretch them out. So you're trying to tighten them up by kind of point your toes or evert your foot and point your toes to the outside. And then secondly will be what we call the proprioception training. So these are what we call the balance trainings that fine-tunes the feedback between how you're placing your foot on the ground to the brain. So next time you put a foot on the ground, it's more symmetric and square as opposed to have a tendency to tilt again. And then if you tried about, I would say, 3 to 6 months of non-surgical options, you still have recurrent ability or recurrent tendency to sprain an ankle frequently, there are surgical options that we can help you with to kind of tighten up the ligament from an interventional standpoint. So there are two generalized good options. One is anatomic repair, which means that we put in actually sutures and anchors to kind of tighten up the ligament on the outside and fix it to the bone, essentially repair it back to where it's supposed to be. And secondly, what we call anatomic reconstructions, and these are a little bit bigger and more involved surgery than the actual direct repair, meaning that we actually take a graft of the tendon, whether it's your own tendon harvest from somewhere in your body, there are a lot of good options, or a donated tendon from someone else to kind of reconstruct where those ligaments used to be and tighten up and anchor into the bone. And those are really good options, just in case the non-surgical options is not successful. And then sinus tarsi syndrome is also a common thing I see in the clinic where a patient complains of pain on the outer side of their ankle. What that means is you have pain right kind of where that red circle is, right in front of that pointy bone in your body. And you see this space is occupied kind of articulation between the talus, which is here, the fibula, and the calcaneus. Now, this picture is a good picture that shows why it's really associated with flat foot deformity, meaning that if you have a neutral foot, you really don't have any pinching or any contact between the bones that we described. But if you have a flat foot, then you're starting having more of pinching or impingement among different bones. Depends on the degree of your deformity. So again, it's such as, same concept as the ankle impingement we talked about before. When a bone and bone start hitting, it will create a localized amount of pain, and usually this is what we call the sinus tarsi syndrome. It is usually associated, like I said, with flat foot deformity, but it is a diagnosis of exclusion, meaning that we have to make sure you don't have any other true underlying pathologies, such as fractures, such as tendon tears. So when you come in with pain here, the doctor or physician you're seeing usually should have a workup to exclude other reasons before having this diagnosis. What we do about it, still, the first line is conservative in nature. So usually, like I said, these patients would have a flat foot deformity. So again, we do some activity modification, make sure we're trying to minimize the weight-bearing activities as much as we can when they have acute inflammation. Orthotics, such as arc support, can somewhat correct the alignment somewhat, so we can minimize the pinching of the bone on the outside. Anti-inflammatory injections. Surgically, these are rarely isolated needed by themselves. We usually try to address the underlying cause of it, which is a flat foot. So usually when we address flat foot in the form of a flat foot reconstruction, we actually address the sinus tarsi syndrome at the same time. And then lastly, common reason for having pain on the outside of the ankle is what we call a subtitle arthritis. If you remember, subtitle joint is a joint that allows us to swivel our ankles side to side. So these are particularly important when you're trying to walk on uneven ground. If someone tells me that I have a lot of pain when I do hikes, walking on the beach, walking on the pebble stone or something like that, but I don't have any pain when walking on the flat ground, I think about the subtitle joint pathology, and this is basically usually associated with previous traumas or chronic abnormal alignment, like we discussed before. What that means is if you have an X-ray, you see a nice clear line of the joint below the talus, but then if you have arthritis, you can see bone spurs popping up in the back, and you have a less clear of a line, like more worn out subtitle joint. And again, first line is conservative in nature. We talked about most of these, avoiding walking on even ground, perhaps a little bit of weight loss to decrease the pressure through that joint, bracing to keep your foot up and down and prevent it more prevent more of a side-to-side motion. Anti-inflammatory steroid injections are good options. Surgically, the option is a fusion, just like the ankle. And basically, we're sacrificing, again, motion to gain pain relief. And this is a kind of example of usually how it's done. We essentially put hardware through that joint and keep it in place, allow that joint to glue together, and people do very well with that in terms of pain relief. Now, if you say, okay, I have pain in the back of my pointy bone, what that would be like. And we think about what we call the Perineal Tendonitis. And if you remember, perineal tendon is consists of essentially two major tendons. And one is perineal brevis, one is perineal longus, and both of them kind of just run their course right behind that pointy bone and kind of into the forefoot. And when we think about perineal tendonitis, we think about this can be associated with biomechanical disadvantage, such as high arched feet. So if you put more pressure on the outside of your feet naturally, then these tendons are more likely to get inflamed over time. That translates into increased ankle inversion. If you have a history of ankle sprain, these tendons, their function is to kind of stabilize your ankle from the outside to prevent ankle sprains. But if you have a true event, you might cause this chronic irritation. And chronic irritation can lead to longitudinal tears. What that means is, tear is within the axis of the tendon, such as picture on the upper right, as opposed to a horizontal or transection tear. If you're suspecting tear, MRI is diagnostic. It's probably hard to see from the picture on the right, right side below that, but you can pick up longitudinal tears from the MRI. What do you do with this? These are actually pretty successfully treated, even if it's a tear, with non-surgical options. Again, short course of immobilization, breathing, therapy, orthotics to correct the underlying alignment issues, anti-inflammatories. Usually these recoveries are slow, but often successful without surgical intervention. Surgical intervention greatly depends on the nature, location, and generally just how bad the tear is. If the tear is small, then we can sometimes repair. If there is just general inflammation without tear, then we can obviously take away kind of the inflammation by debriding away the scar and irritated tissues around the tendon. But if the tear is severe enough, sometimes we have to utilize another tendon to transfer it to this tendon and allow it to kind of do its job. Now we're moving to the inside of your ankle. Now that's a pretty broad area on the inside, but a lot of times it covers one thing of pathology, which is what we call a posterior tibialis tendonitis or dysfunction. So tendonitis just means that you have inflammation, but when you have dysfunction, it means that that tendon is not really doing its job anymore. And usually this is a vicious cycle. So again, we're seeing kind of this issue often is in a spectrum of overuse. So if you're standing on your feet a long time, walks a lot, in your daily activities, you're more prone to have tendonitis. If you have tendonitis in this area, that translates into pain on the inner side of your ankle. And that can cause, again, tendonitis of the posterior tibialis tendon. And over time, if it's not treated, it can cause what we call a dysfunction. So when the tendon kind of stops doing its job, you see the arch start dropping, because the purpose of this tendon is to kind of hold the arch up. And that progressively translates into a flat foot, and that causes overall alignment issues, and that can cause more pressure placed through the tendon on the inside of your ankle, and so on. So when we see someone with pain on the inside, I often just look at their feet, their alignment, have them stand up for me, and often I see a flat foot deformity. And to tell kind of the stages of the tendon, which is a kind of a busy looking table on the right, but I'll break it down for you, is usually the most important thing is we look at a single leg heel raise test. So basically, it's the same ankle on the picture below. When your ankle is flat on the ground, you see everything is turning out or flat foot, but when you try to have them toe up, often it corrects into a normal alignment. So that is certainly a good thing. So if you look at the table on the right, this is the most important line there. So it depends on the different staging, and that really governs how we treat it. In stage 1, there is no deformity, meaning that if you look at their feet on the ground, you see a straight neutral alignment. So that's tendonitis. The arch hasn't dropped. There's no harm being done. And usually that's get treated very well. It has good outcome with non-surgical options. In stage 2, basically means that you have a low deformity, meaning that the tendon is inflamed enough to kind of lose its tension and lose its and gain laxity, meaning that you have a little bit of flat foot, which is a picture you see on the left. In stage 3 is when you have a flat foot for a long time and you're walking on it, and then the joint, different joints in the foot starting to kind of adapt to that kind of uneven alignment, and that can translate into different arthritic changes or degenerative changes across different parts of your foot. In a way, it won't be able to correct anymore, meaning that if you have them toe up, it doesn't translate into a neutral position. So that's stage 3. And stage 4 is, you can imagine, if the flat foot is too great and it's being ignored for a while, then you can start involve the actual ankle joint and translate into arthritis in the ankle from a malalignment standpoint. So what do we do with that? We kind of briefly discussed in stage 1 and early stage 2. These are pretty successfully treated with non-surgical options that consist of a number of things to kind of correct or temporarily correct the alignment, such as orthotics. It prevents progression, but temporarily corrects alignment, but not permanently. Comfortable shoes, activity modification, physical therapy consists mainly of the strengthening program to including high repetition, low resistance. Idea is to kind of increase the tightness of that tendon that is somewhat irritated to prevent a progression into a flat foot. If you become a later stages, then the treatment option becomes a little different. If you're stage 2, meaning that the joint is still not arthritic yet, but you have a deformity, we can do somewhat of a soft tissue reconstruction to correct the alignment of the foot, which is in the form of the flat foot reconstruction. But if your foot becomes more arthritic in a flat foot deformity, then we are essentially trying to glue the bones back together in a good alignment, which is what we call the arthrodesis or fusion. And then, but if the alignment is bad enough, not only involves arthritis of the foot, but also arthritis of the ankle, then we actually have to address the ankle, which is what we call pan-talar, meaning we're fusing everything around the talus, which is the center of our foot and the ankle, to a better alignment and keep it that way. So, what if you're having pain in the back of your ankle, which is heel area? So it could be kind of lower down below, or it can be a little bit higher up above. And these are most commonly what we call Achilles tendonitis. Achilles is the biggest tendon in our body, and it lines in the back of our calf and connects the calf to the heel bone. And these are often conditions due to overuse. Now, I think it's important to distinguish there's 2 types. One is what we call the insertional, which is pain kind of a little more lower on the actual bone of the heel, and 2 is non-insurgent, meaning that the pain is more in the soft part of your tendon, more higher above. Now, if you have insertional Achilles tendonitis, you might find yourself to have a bump in the back of your heel. And often people really have a hard time looking at the back, but most people actually don't notice this bump until I point that out to them. And non-insertional Achilles tendonitis would have a bump a little bit higher in the soft substance of the tendon. So for the insertional Achilles tendonitis is usually caused by a repetitive inflammation that translate into a more bony metaplasia, meaning that inflammation causes formation of calcium bone in the back of your Achilles where it attaches to the heel bone. And this is commonly seen with what we call a Hageland's deformity. So what that means is if you look at the picture on the right, the X-ray picture on the right, inside that blue triangle there, you see the back of the heel bone has a little hump to it. So that's usually what your mom gave you. So you kind of grew up with that. Some people have a little higher bump and some people have a lower bump. So we know that people with higher bump has more risk of developing tendinitis there. As you can imagine, if you point your toe up, like if you are walking forward repetitively or hiking uphill, that bump tends to place extra stress or friction to the Achilles tendon in the back of it. So that's kind of a theory of why people with a tall Hageland's deformity is at a higher risk of getting Achilles tendonitis that way. When in terms of non-insurginal Achilles tendonitis, is thought to be a degeneration of the tendon, usually 2 to 6 centimeters above the heel bone, due to poor blood supply. We know this is kind of a watershed area, so if you have an irritation of your tendon, it tends to take longer to kind of heal up by themselves. So we usually see this with overuse, more often kind of acute increase of activities without any transition. We see this in a lot of weekend warriors, meaning that they're pretty stagnant through the week and they get their exercise in with running and with activity on the weekend. So you see this acute bump or increase in activity level. Sometimes medication can cause side effects that harms tendons. There is some genetic predisposition to it, but mainly overuse is the big thing. And how do we approach the treatment? Again, the first line is non-surgical. And to me, I approach it with three different phases. Phase one will be resting. Second phase will be rehab. And third phase is transition to regular activities. And I'll explain to each individually. What resting means is if it hurts in Achilles, again, it's due to overuse most of the time. And we want to rest it with a combination of modifying activities, short course of immobilization, meaning that we kind of rest the tendons completely by putting them in the boot. Sometimes we do a heel lift to kind of minimize the tension through the Achilles. Heel pad to prevent the friction in the back of your heel when you're in contact with the boot or shoes eventually, anti-inflammatories. And second phase starts when the pain in the back of your heel is gone. Essentially, when I press in the back of your Achilles, they say, oh, pain's completely better. And that's when they start be ready for rehab. And that consists of early phase of gentle calf stretches to gain the flexibility back. And they're doing with that, they'll transition to what we call the strengthening or eccentric strengthening late in the course. There are options of itophoresis, which is a delivery of medication through electrical current, which can be very beneficial as an adjunct. Now, if you have thick therapy and you do well with that, then you're ready to gradually transition to regular activities. And these are usually done maybe 2-3 months after the initial visit. And with these three different phases, I find very successfully treat over 90% without any kind of surgical intervention. Now, if you fall into the less 10% that has persistent pain, an issue that come in conflict with your daily activities and desire to be active, then there are surgical options that can help you. And the surgical options are different between insertional and non-insertional. For insertional, I think about the problem will be it needs to be addressed from a bony level. So if you have a Hagelin deformity, we usually take that away from the surgical perspective. And then oftentimes we inspect the Achilles tendon and see how damaged that is. And sometimes if it's just a little bit damaged, we take away the damaged portion and repair it back together. If it's too damaged, then sometimes we do a tendon transfer, meaning we harvest another tendon and kind of combine with the remaining Achilles tendon and allow it to do its job properly. For non-insertional, it's more of a soft tissue thing. So sometimes that can be associated with longitudinal tears, just like perennial tendon associated with chronic overuse. So you can see it's usually in line, the tear in line with the axis of the tendon. And sometimes we can stitch that, repair that back together, and what we call the tuberization. But if the tear is too huge or too big, then we have to do another tendon transfer again to kind of help out do its job. And that includes my presentation today, and I'm happy that I have this opportunity to talk in front of you guys, and I'm open to any questions that you might have. Thank you.
Thank you, Dr. Liu. We do have a couple questions. With ankle swelling, where does the fluid go after the swelling in the ankle goes down?
So with ankle swelling, the fluid can be from the actual joint, or it could be from kind of more in the superficial soft tissue. Now, if you have ankle swelling from a joint perspective, that's usually what we call a normal joint fluid, and that gets irritated from whatever is inflaming the ankle joint itself. And usually we don't really do anything. We actually treat why you're having an ankle inflammation. And that joint usually, that fluid usually gets reabsorbed once the inflammation goes away. Now, if you have swelling from a superficial perspective, meaning skin, soft tissue, muscle layers, then that goes away with resting. Again, take away the inflammation from that perspective. And that's usually swelling from a soft tissue level. Usually that's from literally retaining fluid from the skin. And that gets better from elevation, from resting, from ice, from anti-inflammatory perspective.
Great. Also, another question is, do you recommend over-the-counter orthotics and arch supports, or is it better to have them custom-made?
So I usually tell my patients, that's actually a very common question I get asked all the time. There are no evidence that customized arch support is superior to over-the-counter unless the deformity is too great. So I usually tell my patients from initially, if you never tried arch support before, just get yourself an over-the-counter one. There's a number of options out there, and they are much more financially doable. They're usually in the range of $30 to $40 versus a customized one. It would be range of the $100 range. And if the over-the-counter one is not appropriately doing its job, then the customized one would become more of an option. So I used to say try the over-the-counter one first and see how it goes.
Okay. Another question we have is, I have foot and ankle pain now, and I'm taking over-the-counter anti-inflammatory meds. At what point should I see a doctor?
I would say if you have pain that been going on for a while, and that depends on, let's say if you have pain just out of the blue versus if you have pain from an injury. So if you have pain from an injury, I would say go check it out if it's more than a week and that's not getting better with any of the medications. Or if you can't walk or can't put any pressure on it, then I would say more reason to kind of seek a health professional evaluation. But if you have something chronic condition that you've been taking anti-inflammatory for a number of weeks or a number of months, I would say that's a good timeline to get it checked out. It should be better by then, and obviously we don't want you to be on medications such as anti-inflammatory for too long because that can have some side effects to your kidneys, to your stomach, to your GI system. So I would say, if it's bothersome to you, that's not getting better over the course of maybe 1 week to 1 to 4 weeks or so, it's probably time to get it checked out.
All right. And one last question. How common is ankle replacement, and how long is the recovery?
Ankle replacement, like I was mentioning, is more of a, I would say, a more up-and-coming treatment that we have. It's not very commonly done. There are a few ankle replacement heavy institutions in the United States, but ankle is just such a natural joint that doesn't really get arthritic as easily as, say, knees and the hips. So it's not very common to have it done in the first place. But in terms of ankle replacement, usually recovery time is faster than ankle fusion. You actually, as opposed to we're trying to protect your ankle like the two bones glued together, we actually want you to start moving your ankle up and down once your skin heals. So actually you're just like your knees and hips, you're actually encouraged to start walking and doing activities right away. The caveat of the ankle replacement is still in kind of, compared to ankle fusions, is still in kind of the early testing phase. We have about 20-25 years of records testing, but again, it's still early compared to the literature we have in ankle fusion. So the selection process for candidacy for ankle replacement is more stringent. So, but if you're interested, absolutely, you can look into a lot of studies out there, and certainly if you like to ask me questions, please contact me. I'll be more than happy to answer more questions in details.
Great. Well, that's all the questions that we have for tonight, and this concludes our program. Thank you, Dr. Liu. This was an insightful presentation, and thank you, viewers, for tuning in. The entire broadcast of today's event will be available on our Facebook page and YouTube.